So my name's Ryan Padrez. I'm a pediatrician, and hopefully brings a different perspective to this work. And I'm on faculty at Stanford University School of Medicine and have been working in some of the community's federally qualified health centers. And as a pediatrician, I was drawn to the work of the primary school, which I'll tell you a bit more, because similar to many of us, I was part of someone working in one of those silos of healthcare, and it was growing increasingly frustrated of how can I work better with our early education systems, our school systems, with our families to truly try to make a difference in kids' health and their life trajectories. And when I learned about the primary school, the primary I'll tell you more about is a new private school in East Palo Alto. I was really drawn to the mission, and this was a school who's setting out to foster each child's well-being by really drawing on the strengths of all the adults around that child, drawing the entire community, including the parents or caregivers, the educators, the pediatricians, the mental health providers. How can we get those teams to work better together? And I was very lucky to join the primary school about 2 years ago. And we really exist because we know that, as we learned this morning, the mental health and developmental impacts of toxic stress are really prevalent in our community, and they're particularly unaddressed in our young children as they get ready for kindergarten. We often start too late. Our public elementary system doesn't reach most kids until the age of 5. We clearly are underinvesting and underutilizing parents as partners in this work. And most critical, which is how I started my narrative, is our systems are just too siloed. And right now it's up to the parents to sort of navigate between the healthcare system, the early education system, and then eventually the K through 8. And so the schematic up here sort of tries to capture what we're trying to build at the primary school, and where we try to bring these silos together and start to focus on what the parent or child may need rather than what the system needs. And so that care can be more coordinated, that access can be simpler for families, and that hopefully we can get to that holy grail where data can start to be integrated across these systems. So, Kai, if you move to the next slide. When I get the chance to tell people what we're doing at the primary school, I want to ground it in sort of some of the key guiding principles, which is there. And the first is that if we're going to open up a new private school, it's tuition-free for our families, for low-income families in East Palo Alto. Right now we have 250 families. We're in our third year. And those children age range is from 1 year old to 6 years old. So we have some early childhood programming, we have preschool programming for 3 and 4 year olds, and then we have a kindergarten and first grade class. And we'll continue to grow with that first grade class through the years. But if we're going to open up an elementary school, we know that on this first guiding principle, we need to start early. We know from a pediatrician and from all the science and the neurodevelopment sciences, this is the critical windows of child development. And we're not only trying to ground ourselves in kindergarten readiness, we're actually trying to set the bar of preschool readiness. How can we start to achieve outcomes for parental attachment, for social emotional development, and for language skills so that our kids are ready to start preschool? And we're starting to invest in some programs that work with families in this sort of birth to 3-year-old range. Our second guiding principle is back to that schematic of how do we start to think about the whole child, and how do we think about integrating supports about what the child may need. And so we set our goals and outcomes for children and not only their academic outcomes, which we clearly care about as a school, but then which drove me to this work as a pediatrician is we start to really look at their children's social emotional outcomes, which we call SOUL, and then their health outcomes. And it's a really fun thought experiment of what can a school start to take accountable for in terms of the health outcomes of a child, and how can we start to leverage that access point of a school much more often to help a child achieve some of their health needs. The third guiding principle that we really care deeply about is how do we work with parents? And as some of the commentators this morning really talked about, is that they are a critical partner in this work. But we also need to figure out ways to support them. And so all our families are engaged in a parent coaching program. They're all assigned a parent coach that's really built on many of the evidence grounded in the protective factors that are there to how do we get parents to be well themselves. So achieving self-efficacy, breaking down social isolationism, learning about child development, stress management. These are with the theory of change being that if we can help our parents start to be well, they can start to then get engaged in their child within the school setting. And so we're investing into some parent coaching that goes on for all our families. But probably most importantly is also on this guiding principle number 4, which is the replicability of our model. We are keen on trying to build a game-changing model that really impacts children's outcomes in a new way, but we also want it to be achievable for others in the communities, especially on public funding. And so we pay a lot of attention to what our per pupil spending may be, and though we're not there yet, we know that we want this to be achievable for other communities, and how can that work? And part of that is partnership, and so that we're not duplicating services, but working better together. And so if you go to the next slide, I wanted to give a little picture of what does our integrated work look like, what does some of our partnership work look like. And so I think first off, one of the things we need to ground ourselves in is what does our school look like for that environment and culture for all our kids, both in the 0 to 3 programming as well as in the preschool and in the elementary school. And that's where we've started to pay a lot of attention to our curriculum and to our discipline policies. And so in our school curriculum in the preschool, we're excited to be working with the Sesame workshop that's developing some new curriculum where we don't break apart academic teaching and social emotional teaching, but rather bring them together as one sort of lesson plan. And we're excited to continue to be working with them on that work. And then in terms of our approach to what does our school look like to protect to build an environment of resiliency, we've invested in a program called Conscious Discipline. If you haven't seen it before, I encourage you guys to check it out. It's based out of Florida, but as a pediatrician, I sort of fell in love with it because it's grounded in the neurosciences to try to really better understand what is that behavior that child is telling us, and what brain state is in that child when they're sort of acting in that behavior. And maybe the most important part, what brain state are you as a teacher when you're responding to that behavior? Now, of course, this is hard work. It takes a lot of professional development, a lot of coaching, and because you can't just plug and play, you also have to build what the school looks like in terms of what are the routines and rituals and sort of structures that you can then operationalize on this conscious discipline routines. And we start to build that even in our 0 to 3 programming and talking to our families. So the next aspect to sort of our tiered supports here is how do we know which children we need to be moving up the ladder in terms of tier 2 and tier 3, and we really want to ground that into better data, and not just a teacher feeling, but more of what can we know about what's going on with the child. And so in the 0 to 3 space, we're really trying to use better evaluation markers of like the ASQSE, the Piccolo, which is a tool looking at parent-child attachment. We're using the Minnesota Executive Functioning Scale, really trying to feel out where that child's executive functioning skills are so that we know which targeted tier 2 supports a child may need. But we're also not going to ignore what's going on in our classroom environments and really looking at using tools like the class or other culture and climate surveys to figure out where we can make improvements there. And finally, we know that doing this work is really most powerful if we're thinking about doing it with partnerships. And so for our mental health work, we were excited this year to partner with Seneca in bringing in their unconditional education model that really matches our tier 2 and tier 3 level, but also equally investment into what does our culture and climate of the school look like. And so it's just like someone said before, it's not just services, but how they really meld and integrate with our school leadership. On the services on the outside, including our medical homes of our children and other county services that may be going on, we're also very keen on working and building strong partnership. And so back to that replicability, as a pediatrician working in the school, I'm not the pediatrician for all the kids, but instead trying to build the systems for how we work together with the medical homes around our school. How do we sign the HIPAA and FERPAs for all our kids so that we can foster those communications? How do we bring the pediatrician at the right time so that data sharing can be there? And most of our children attend a federally qualified health center just down the road named Ravenswood Family Health Center, where about 75% of our families go. But even just the healthcare system is one aspect. Our families are also in touch with many of our county programs, including home visitors and other social programs. And so how do we bring them to the table as well so that we're, again, not working all in isolation and we're instead starting to work more as a team? So that's a flavor of what we're up to at the primary school, and I'll save my many lessons learned so far here and some questions to come in the next slide.
Awesome. Great. Hi, good morning. My name is Cami Murphy. I'm program manager for CA Help, and you were listening to our CEO, Janae Holt, a little bit earlier, so I will tag into some of the work that she was talking about. So the mission of CA Help is a relentless pursuit of whatever works in the life of a child, and that is true to our organization. You see the bubbles there. It doesn't quite represent how that fits together. I couldn't find a little graphic that was all similar in this short amount of time. But I will say that, as Janae mentioned, we have 3 branches that we're working out of. Our own organization is working to build our own interdisciplinary team and working continuously. It's not a job that is finished, it is a continuous work. So we have the Desert Mountain SELPA, the Desert Mountain Charter SELPA, as well as the Desert Mountain Children's Center. Now, sitting in this room, I know we have educators as well as mental health professionals, and so depending on your lens, might be the lens you listen for today. I'm going to speak on behalf of the education component. That's where my area is, and so some of the work that we get to do. We are a proud recipient of one of the Triage grants and are really excited about that work. And when we wrote is we said, hey, we have some really great strengths in our organization and areas to work toward. And what really are those? And really to identify what that looked like, we need to look at, again, some of those strengths. We know that our Desert Mountain Children's Center provides a lot of really great resources to our schools. We know that. We're in our schools. We're from our schools. And how could we bridge that and interconnect the supports of our education community that I was from and am from, and I was a teacher, I was a school counselor, an administrator, and would have students leave the classroom and then come back, and I didn't know, like, what's happening, right? What's happening there? So even with some of that real working experience, or organization really being founded on, and we have a lot of experts, well, we need to come together, break down some of those walls so that we can spread it out, as Ryan was mentioning. How do we sustain this? Go ahead and move to the next slide. One of those strengths that we focused in was really some of the work that we'd been providing in the K-12 schools for PBIS, the multi-tiered systems of support. How do we set systems up to make sure that we can organize our resources? So resources, sometimes when I say that, think of textbooks, teachers do. When you hear resources as an educator, you're like, oh, what kind of materials do I have? Resources are humans, right? The resources of humans getting in and working with others. So how do we organize our resources, build systems that can last for us as well as others, replicate it, much like you were saying, and move on? So what we have written about and have really put a lot of effort and focus in on is building this strong foundation. Now, I appreciated this morning what Carla mentioned. I don't even see her in the room. That's okay. We're going to have to say her name a bunch of times today, but is that Tier 1 supports don't work for all the students with all those needs. But here's what we know. You build that strong foundation there, and you can really organize your resources for those students that really need those Tier 2 and Tier 3 supports. We know that is the real working. We have clinical support. We have additional special education specialists. But we really need to make sure that we're identifying the students that need those supports. And so we were doing that. The interconnected system framework is a structure for organizing a PBIS or MTSS model in with school mental health. If you look on the slide there, we really want to make sure that we're providing the capacity of the entire school system to create safe, predictable, consistent, and nurturing environments. And when we do that, we can then build that system together. We can continue with the relationships. So if we can keep taking a snapshot of those problems that come up and kind of reframe, are we looking at this from the safe, predictable, nurturing environment lens? And then we can move forward. Go ahead and you move to the next slide. Don't memorize this. I just wanted to give you a visual. We talked about adding visuals. I just wanted, let me even see, yeah. I'm going to peek at the slide. I just wanted to put this in there as a frame for how we started taking a look at that. We know that we have services for early childhood supports. We wanted to make sure that we were equipping our educators in the preschool classrooms, to be specific, using a model that we'd use similar in K-12. Guess what? They're different educators. Educators in preschool are very different than educators in K-12. I see a couple claps. So yeah, kudos to you. And when I say the word educator, some of you think teachers. Guess what? They're all not teachers. We have paraprofessionals. We have folks that are working that really need to learn the same language that the rest of us sometimes talk at. And so really breaking it down, not just for the early educators. It just happened to be that they schooled us. That's exactly what happened. They said, hey, here's what we need from you. So we broke that down a little bit more for them. So in a model of training that we are putting out, training, coaching, really working alongside, we really needed to pair that with content, coaching, building up their skill expertise so that they then could turn and be the trainers themselves. And so in that model that we created, really looking at building up a strong workforce, the strong educators that are working with the students. You can go ahead and, if you click one more time. Oh, yeah, you can click through that. That one's good. Thank you. Using data, we really as well wanted to make sure that we had a foundation in data. We need to know where we need to work. We need to take some data, whatever it is. We can agree with it or disagree with it, but it is data that we're collecting. We're collecting the best data on every given day. Might not be your best data by tomorrow, but it is your best data for today. Taking that data, using that data to make some good, sound decisions, and bringing your partners back in together to say, how do we move forward? Our model is really utilizing the universal screening tools so that we can identify students much earlier, as well as helping make decisions early on. And no matter what your lens, clinician, educator, we're all speaking the same language. And in that next slide, you can't read that other part. I'm just going to give you this information that says, no matter what the behavior might be in a classroom, because as an educator in a classroom of students, that's one of the concerns. If you talk to educators, they're like, but this kid, fill in the blank. They need those skill sets at their ready so that they can reteach, they can build relationships, they can correct as needed and steer and mold and look at that whole child. Again, we're using that frame of the early childhood PBIS model, that multi-tiered system, as a system so we can fill in with practices and use that data to guide decisions, all creating the safe, predictable, nurturing, and consistent environments. All right, and funding for sustainability, there's a few of the funding sources that we have been using in our organization of CA Help. This was our a bunch of the different tools, so if you can snap that or ask. I see some snaps. You can ask, we'll give you a picture of that. Some different funding models so that we could continue to build sustainability and interconnect our systems together.
Good morning. It's afternoon almost, but not quite. So I started this work in Monterey County, actually as a nonprofit provider, serving the schools and community mental health. And in 2012, I was brought into the county to help start an IEP-driven service called HEART for wraparound. So those of you that remember AB 3632, which was a significant change for everybody probably here in this room. That was the golden thread that led me here to this work. So I follow that golden thread. It just never steers me wrong. So when I landed in Monterey County, I was doing the direct service myself, and behavioral health only had the contract to serve students in special education. And this list of agencies here, you can see there's several of them. In 2014, Monterey County Office of Education received this School Climate Transformation Grant. So that's what brought all of these people together. At the time, I promoted into a different position, and I joined that team, and I started training in youth mental health first aid. And that was my first dabble in public speaking, and I will join many other people. And it's a lot. I look out into this room, and it's amazing to see all of you, but it's mildly terrifying. This work, when I first ended up in this group of people, I didn't really know where my place was. And that was fine, because as we're learning, we're trying to figure out where our place is and where is our function. So with this collaborative, we have accomplished incredible things. In Monterey County, we have a student population of about 77,000 students, and our rates of trauma are just ridiculous. I mean, the things that these students are bringing into the school doors every day, unimaginable. So one of the reasons why Monterey County Office of Education was awarded that grant is because at the time we were one of the most violent places in the country. Next slide, please. So, Cami, we just met. Cami mentioned the interconnected systems framework. Is anyone familiar with this framework? Please. So it's soon, this whole room will raise your hand because this is what's happening in mental health. What I've done here with this Venn diagram here, so Monterey County Behavioral Health serves all of these systems already. And it's going to vary, I think, across the counties. But behavioral health, if we have students that are on probation, they are mandated to receive our services. If we have students that are removed from the care of from their parents or caregivers, they are mandated to receive our services. Anytime we have a call out with law enforcement and it's a suspected mental health issue, we have a behavioral health clinician that accompanies law enforcement. Anytime a child goes into our county-operated hospital, emergency department, behavioral health is there assessing. And then in the schools, that is our link, that is our door in. So the thing about connecting these systems is that we are connected through behavioral health, and the common denominator is school. All the kids, they have to go to school, that's the law, and if they're not in school, we go get them. We try our best to try and get them back into school. So my intent in creating this diagram, because I was thinking about it, how do we really make this point of this is the entry point into the schools, is having a county behavioral health person inside the school buildings. They're one phone call away from all of these systems. One phone call away. I've experienced it. I experience it daily. Next slide, please. So when I'm 2 years into this position, and I have a very large team, 70 staff total, and we are in 122 schools in Monterey County. So if you do the math, that's not enough. And we do our best. And the thing is, we have separate contracts. So in Monterey County, our SELPA, they pool all of their funds together, the mental health funds, and it's a collaborative, it's a cabinet, and they make decisions together, so they share their resources. And then with the interconnected systems framework, the big idea is that you change the role of the clinician. They are not the siloed care, which is before I redesigned the model, it was a clinician providing a service for one student, going into the next school, providing another service to a student, and this was happening, it was chaos. And the idea is that we want these clinicians to be embedded in the schools and the cultures and the communities and understand what is happening, because each school building is its own city. And in Monterey County, average high school in Salinas is 3,000 students. That is a lot. In the high school district, I have 10 clinicians serving that district, and the day-to-day issues are life and death, seriously. And it's not, so the need is really, really high, and as all public service agencies, we have fixed resources. So we really have to figure out how we're going to meet the needs of the mental health needs of the students. So where I have two sets of both contracts, so I have 10 districts that have general education contracts with behavioral health. And so where I have the SELPA contract and the general education contract, I can have a clinician go in and serve both populations. Right, big idea. So what it used to be that when we got a referral for a general education student, we had a clinician, and then maybe they would add that service to the IEP. We changed a clinician because it's a different funding stream. But to me, these are all students. We don't need to separate them into piles. So next slide, please. That's not as pretty as it's supposed to be. So pretend that's a triangle. You can't see. So basically, the visual is it's a triangle. Can't really even, I don't even have it on print. So triangle, what I worked really hard to do is to speak the language of the schools, because they're really hard at work at implementing PBIS. It needs to make sense to them. So the thing with county behavioral health, we're billing Medi-Cal. And I love Medi-Cal. I know that's not everybody loves Medi-Cal. I love it. We need Medi-Cal, because the thing is, there's room enough for everyone at the table, and we need to share our resources. So when a student needs behavioral health services, we can serve them, but if they don't need them, we have other providers to do that. So this is a tiered diagram. So at the bottom, I spend a lot of my time training. At the bottom, you can see self-care for educators. Who here is tired? Anybody? You're tired? You're fried? There's a lot of stress out there. So I've been going around to all the districts, anyone that will listen and give me some time to really help the educators figure out how they're going to develop self-care plans for themselves, because the work is so hard, and a lot of people have families as well. So when they work all day and they go home, they have to take care of their families, and we cannot pour from an empty cup. So our public service providers, so that's schools, that's behavioral health, anyone that's serving, those are meant to give out. They're not designed to fill us up, so we have to really be proactive about that. The other types of trainings that we provide, suicide prevention and response, the critical incident stress management. Mindfulness is the theme across all 3 tiers, because that is one movement that I believe very strongly in. We don't need to wait till a student needs behavioral health services to teach them how to breathe. It's really a skill, or it's something that we need to be able to regulate both the adults and the kids. So we've been working together with our County Office of Education and sharing funds. So the School Climate Transformation Grant, that's been used to fund mindfulness training. We've trained about 600 adults so far with this funding. When you get up to the top, people ask me what the difference between a nonprofit provider in our community that's not billing Medi-Cal and then the Monterey County Behavioral Health is we have county psychiatrists. So if a student needs medication, we can provide that. And then if they need home services, that's huge. We know it starts at home. So if they need home services, we can provide that as well. Next slide, please. Okay, that one is also supposed to be a triangle. Alrighty, so I was trying to provide an example of how our funding works. So I want to give Lisa Eisenberg credit for this idea, because I was on a panel with her a little while ago, and she had this amazing way to illustrate funding in tiers. So at the bottom of tier 1, those are the cost of our services. The administrative cost is rolled in. So basically my salary, my supervisor's salaries, those are, I don't have to bill by the minute like the clinicians do. So I can go out and provide trainings, as many trainings as I can provide. When we get the School Climate Transformation Grant, that funds the Tier 1 trainings as well. So we share, and when we do our trainings, we integrate. We bring everybody together, so it's not like a training for behavioral health and then a training for the schools. It's everyone in the same room. We have, so the funding. So SELPA, they have their IDEA funding, and our general education contracts are funded through the LCAP. So we bill Medi-Cal, and the difference so there's a formula, and we do it equitably so that because we have different Medi-Cal rates across the county. So we have, the peninsula, which has different, so Carmel is very different than Greenfield. We're a very expansive county, so we make it equitable based on the Medi-Cal percentage rate of that district. And so the cost it's not like super minimal, but it's enough to where we can provide that full continuum of service for the students using the additional funds. Next slide, please. And that's it.
Can everybody hear me okay? Okay, in the next 10 minutes, I'm going to distill 30 years of collaboration into 3 slides and a 260-page grant application in 1 slide. So let's go. Start on the first slide. So this is our system of care. We were formed in 1998. By really a declaration of our Superior Court judge to bring together the heads of the youth serving agencies in Placer County, and that was kind of the birth of our integrated system of care. Over those 30 years, it has evolved to include a leadership team that's still chaired by the Superior Court judge. I'm a little mortified I didn't put her on there, but she's not here, so nobody from Placer telling me. It's an integrated leadership team, you can see, child welfare, probation, mental health, education, who meet now every other Wednesday at 7:30 in the morning, really for the last 30 years. Focused on problem solving, how do we do this work together? Down a tier, we have an executive leadership team that is really the group that does the bidding of our leaders. So we affect the policy practices, solve problems that come up within our system of care. We help to make it much easier to affect that integrated work so it doesn't affect our children and families. So we're the people who are supposed to solve those problems. Recently, our deputy chief probation officer, we were reflecting on all these years, and he said, you know, a lot of what we do doesn't even happen in this steering committee or this executive committee. It just happens through relationship. And I think Steve and Richard talked about that. It's the relationships that have formed over this time that are most valuable. And at the staff level and management level, we have integrated teams. And what that means is they share space in cubicles with each other. They're co-located. They share data systems. My education staff can go into the child welfare system, look up students for foster youth services. It is truly an integrated team, side by side with probation, our youth partners, our family partners, all sitting together in our Roseville office and our Auburn office, trying to do this work for our children and families, right? And then we have 3 sets of decision-making teams for students who really have those high needs. We've heard about CFTs earlier today. We have something called a Family Resource Community Collaborative that helps support our students and families and children who have the most intensive needs. Go to the next slide. Here's an illustration of kind of what those teams look like and other agencies that are involved. So it really is, if you could picture the people that you brought with you today, many of you, operating together around a child and family. And now in the last 5 years, really operating together to look at prevention and early intervention services. So working together in an integrated way. The next one. So the types of services and funding that we do. It's a long list. I realized I even forgot to add some of the services that we're doing, but really the point of this slide is when you look at a need or a problem in your community, how do we join together, develop a program or practice to implement around and come together to help support that family? I'll pick on the Crisis Resolution Center. We have probation here today. That's an integrated project that we have in Placer County where we serve children who are at high risk or imminent risk of placement into the child welfare or probation programs, right? So it's an actual physical building. It looks like you're walking into your grandma's house where young people can stay and work on those relationships and high needs issues that happen. This project is funded by the probation department. So to the tune of over $500,000 a year. You would never know walking in there. It literally does smell like cookies sometimes when you walk into the crisis center. There's quilts, everything you'd imagine. But every week, child welfare, probation, education, the staff at the center, probation get together to problem solve. How can we help this family? How can we help get the family the services they need in the community? There's a number of other projects on the your left-hand side or your right-hand side of that. It's how we look at funding. Again, when a need comes up in our community, we really look at what does each agency bring to the table. So how do we braid local control accountability funding, like our LCFF funding? How do we braid other education dollars, child welfare dollars, probation dollars to solve the problem? We don't start with, hey, I have this pot of money, let's do this. Really look at what's the need in the community and what are the toys that we all bring to the table to help solve that problem or meet that need of our community. So everybody has something, and a lot of times it's just your time, helping staff participate in integrated meetings. attending different projects. Recently, very recently, this last few weeks, we launched a new project with our Child Welfare Services Agency to help support children who've been commercially and sexually exploited or having violent relationships. Funded by our system of care, social services, staff are hired, embedded directly into the education system to support kids. It is a project that went so astonishingly smoothly because of those relationships to solve and help support our most needy youth, right? Okay. So here's one page, or one slide for a 260-page grant application. So for the last 30 years, we've been doing the work way up here, right? For the most intensive needs for children and families in Placer County. Our project under the integrated triage grant is to move down to a school. How do we take a system of care approach, much like Kacey was describing, and Cami, and move that right into a school site and create a wellness campus at a school site with an integrated team that involves, these are just some of the people that might be on the team. It's not you have to have each of these members, because I want the people at the school site to look at the ecology and environment of that school and decide, who do we need? Maybe we need a community provider who helps support homeless youth because we have a high homeless population at that school. It might not be the same next door in another school. But who do we need on our team to create that wellness campus? And then what systems, data, and practices do we use to achieve those outcomes for our kids? So how do we integrate the data systems together? How do we have policies so we can talk to each other? Because the first few weeks that team gets together, they're going to say, well, I can't talk to you. That's unethical or whatever. I'll refrain from using bad words. Or whatever policy they think they have should not be a barrier to helping our children. We should be able to talk, communicate, and solve those problems behind the scenes and not have our kids and families be exposed to our sometimes barriers or roles that become barriers, right? So that's the idea of that left-hand side, is to achieve those outcomes. You really need your systems, data, and practices working together.
Hello? Too loud? Well, the bad news is I'm going to tell you a 30-year-long story, but the good news is I talk very fast. 1989, the school district that I was born, raised, grew up in, and started and hoped to end my career in, had to go bankrupt. And with our 30,000 plus student population, we were cut down to 7 psychologists. Our CBOs, our mental health providers, our agencies, our counselors, everyone was cut who was coming into the school. We had many years of recovery, and as a trauma-informed trainer myself, being a psychologist, I continually tell my staff and the people that work with me that, what we all know that work with people of trauma, that it's about the relationship. And it just takes that one key relationship, and whether it's the mother or not, it's that key person who can make a difference in the lives of the children. And as I look over at my table today that is full of community mental health partners and school district partners and people in the back of the room from other SELPAs who've graciously let me steal their ideas and their programs and replicate them, I'm just reminded of the partnerships that we have with the people. And as I hear about the lenses, I forget which lens I'm looking at most of the time. I forget if people are mental health or school district. And a lot of times we'll be sitting around the table and I'll even forget their titles because they're by first names and they're bringing programs to our schools. We grew from, we had initially Mental Health Services Act grant through County Mental Health, and we were able to provide school-based services with 8 CBOs. We have 5 school-based clinics that are run by school psychologists who are also therapists. We have a wraparound program. And we now have 17 full-service community schools. We have full-time coordinators in those schools, and all the high schools, the secondary schools, have a health center that is staffed by doctors, public health, mental health. We have a lot of mental health services coming into our secondary schools. So I'll just kind of fast forward beyond, because the reason I was excited to come here today is to talk about our new model. And we are in the process of data collection. This model came out of the Breaking Barriers conferences that we've attended the past few years. We've had partners sit at the table with us. We're doing the problem solving and the program planning that we're going to continue to do the next 2 days that I'm sure many of you will be involved in. We went down to Desert Mountain. We visited their program. We loved their program and their care classroom. And we kept talking about, what about these little kids? We're really bringing in service to the secondary. And we've got some school-based clinics in the elementary, but what about the really little ones? Because it's that very first relationship. Kindergarten can go south so quickly, that first year of just being sent out of the classroom or having the problems. The other kids aren't playing with the kids. So we thought a lot about that model, and my concern being a single district SELPA was that if we take those kids out of the classroom and do the wonderful early intervention that I saw Desert Mountain doing, how are we going to get them back in there? How are we going to make sure the seat is not filled and that they're integrated back? So with one of our CBO, one of our partners, Seneca, we actually started this year a K-1 collaborative model classroom. And we are doing 2 schools where we are identifying the kids at preschool. We know they're coming, we're told. And we meet them right at the beginning with their parents with a full service program around them. I think you've got that one. So far, again, we're in the first semester, and there are lessons learned, and I'll be happy to share those if we have time or later. But what's really magical about this program is I have first grade teachers coming up to me and saying, when's our kid coming? When do we get our target student? The amount of support that's being poured into the classrooms for our target students is affecting all the kids. We have a behaviorist coming in. We have a mental health counselor on site who's able to serve any of our Tier 3 kids that need it. We have multiple funding so that we don't have to ask the question that I often ask, are they Medi-Cal eligible? But it's really exciting what's happening with the teachers. And the K-1 teachers, as a result of having a mental health clinician attached to their classroom, dealing with just a couple target kids, all of the interventions are changing within the classroom. What the behaviorist does with one automatically just completely changes the classroom culture and the environment. And our hope is with this model, and like I said, we're doing some pretty serious data collection, is that as those kids move on to first and then second grade, they'll need less, and the teachers will need less. And we can move the model up as our kindergarten and first grade teachers become so naturally accustomed to doing what some of these kids need in the early intervention stage. So that's kind of it. Yeah.
Oh, great, great. Okay, so Monica and I asked each member of our panel to reflect on the lessons that they have learned. And we hope that they can quickly go through those and really help us think about, as a collective, how we can move this work forward. So we'll start with you, Ryan.
Sure. Yeah, I think probably many of our lessons are going to overlap. And a couple of ones that came to mind as we're a young school, we're in our 3rd year, and one of the things that Carla also mentioned this morning was that this integration work is hard. It's messy. When you bring to the table a lot of different perspectives of social work, mental health providers, pediatricians, early educators, which are a little different than the K through 12 educators, and people have different perspectives on what the sort of the order of operations and what needs to get done. And this is particularly true when trying to determine the best approach in supporting a child. And when you have mental health, early education, pediatrics all at the table, there can be sometimes different perspectives of where to start. So that's some of the lessons there. Another one that really stood out is also that this 2-generational support is really critical for this work. Not only for mental health supports for the parents, especially for the early education setting, but also how to really support our families in terms of their readiness to engage in these systems. Some of our best successes have been when that parent coach that's working with the family can spend some time, sometimes weeks, sometimes months, to sort of get over some of the stigmas of when you just use the word mental health. And how do we start to have a family be ready to accept those services and work with those services? One that really stood out to me as a pediatrician is particularly the gaps in services for both mental health and behavioral health supports for children, I would say ages 3 to 8 years old in our system. And I think there's some incredible work going on in infant mental health models that are working in a 2-generational way. There's some incredible mental health work going on in elementary schools and middle schools. But that age between 3 and 8 years old, it's really hard to find therapists that are ready to engage in the right therapy and therapy where families can access. And this is particularly true for kids prior to where we want to put a diagnosis on a child. And so often you need that Medicaid diagnosis to access some of these different services. And it's what drove us to bring so much of the mental health into the school, because we just couldn't find it in the community in an accessible way. And then finally, so much of our model rests on this power of relationship and how we build resiliency in our children, and the teachers hold a critical role in that relationship, but that also requires investment and capacity building for that teacher, not only for programs like conscious discipline, what I mentioned, but also mental health supports for the teachers and other caregivers that are there providing for the child. So that's some of our early lessons.
Yeah, lessons learning is how I like to look at this. Lessons learning. So some of the ones that I will highlight are that educators and mental health practitioners are both experts in their practices, and that's really exciting, and we need to really make sure that we're honoring those pieces. However, we really want to make sure that we're focusing in on the systems that those are relying on, but often the language of our specialties gets in the way. And so we really need to make sure we're having language alignment. Who's doing what? I put that in quotes. I'm not sure that it's up there, but who's doing what and what does that actually look like? So we can call it the same thing, even if we align our language, we're not ever quite sure unless we specifically talk about what that actually looks like for students and our families. So aligning those pieces, focusing a team using some type of data. The best laid plans could fall apart with just really good intention. A lot of us we're here, we've all shown up, we all have great intention. Unless we're heading in some direction together, it could fall apart. And that really is damaging on some of those relationships. And then it takes time, sometimes a lot of time. So going slow to go fast makes some people uncomfortable. It makes me uncomfortable. A lot of times, if you know me, I'm like a jump in and let's get it done. However, we have an opportunity with this new grant to just kind of hang on a second, take what we know works, and really build that foundation there. Are the lights turning off because it's time? Oh, done.
Okay. I would say one of my major lessons learned is that merging cultures is tricky, and having patience with that, and not just staying the course. If you believe in what you're doing, stay the course, and people that are with you will remain. And the foundation is critical. So your tier ones are essential. That's just where we start. So having PBIS structures or the MTSS frameworks in place, that's our primer before we integrate the mental health, and that's important. So
now that the mood lighting is all set, my PBIS friends in the audience will recognize this here. My lessons learned really are 5 things, and I wanted to state them positively. We need to be patient with each other. This is hard work. Collaboration is hard work. We speak different languages. We sometimes don't understand the languages that other agencies speak. We need to be transparent. And be transparent about how we're feeling about the collaboration and the perspectives that we have. We need to be collaborative, truly collaborative, and look at what do we bring to the table to share to solve these problems for kids and families. We need to be responsive, and we need to be enduring. This is hard work. And it takes time. It took 30 years to get to where we are today in Placer County. Some of you are at the beginning of the journey, some of you are along the way. But I would encourage you to look at this differently and say, are we being patient? Are we being transparent? Are we being collaborative? And if you ask yourself those 5 questions and the answer is yes, we're doing that, your collaboration is on its journey.
So my number one lesson learned was no matter how much groundwork you lay and how much you talk to people and make sure that you have ongoing communication, that work is never done. And to continue to make sure your school community, your entire community understands what it is you're trying to do and has a voice and is able to let you know how they're doing.